This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted you're with us today. And our topic today is going to be some of the common forms of liver disease and also transplants related to the liver. We're delighted that we've got with us today Dr. Narayanan Menon. He's the medical director of Medical City Liver and Digestive Disease. He also serves as the medical director of liver transplantation at Medical City Dallas in their Transplant Institute. Welcome to the show.
Thank you. Thank you for having me.
You know, what would you say generally are the most common liver diseases?
Well, everyone is very familiar with alcohol. But what one has to remember is that in addition to alcohol, there are other forms of liver disease and other causes for liver disease. In general, we have two forms of liver disease. One is an acute form and the other one is a more chronic form. And some of the examples of the chronic forms of liver disease that are getting more common are diseases from being obese or having high levels of cholesterol or triglycerides in your blood, and that's commonly known as fatty liver disease. We also have had a number of people with liver diseases from infections such as hepatitis C. In addition, we also have diseases that can arise from congenital or hereditary abnormalities, such as iron overload and copper overload. But in general, these diseases are much less common.
What about other forms of hepatitis? Can they cause liver damage?
Yes, sure. I mean, they've numbered hepatitis viruses. These are viruses that actually infect the liver, and they start from hepatitis A to B, and then you mentioned C, and there's actually D and E as well. And they all present differently and can cause different signs and symptoms. So, for example, hepatitis A is transmitted through food and water, and it causes an acute inflammation of the liver. And if patients can overcome this episode, then there's no underlying liver damage. Hepatitis B, for example, is transmitted through dirty needles and blood and body fluids. This causes a more chronic form of the disease in a few people.
You know, you mentioned A and B. I'm just curious, what transmits hepatitis C?
So hepatitis C is also transmitted through blood and body fluids. So it is transmitted generally through the use of intravenous needles for drug use. It was only discovered in the 90s, and prior to that, patients got hepatitis C from blood transfusions because this virus wasn't discovered then. So once all the blood that was transfused came to be tested for hepatitis C, the most prevalent form of transmission of hepatitis C now is through the use of intravenous needles for drug use.
You know, you mentioned obviously at the outset alcohol, and I think we've certainly all heard that. But what are some of the things other than moderation in alcohol that you recommend to help protect the liver?
That's a very interesting question. You can broadly kind of divide this into two things. One is make sure that you are screened for specific forms of liver disease, such as hepatitis C. And if you do find them, then treat them, because that will certainly protect your liver and, in fact, may actually improve liver function. The other way is to be healthy and lead a healthy lifestyle. Use processed foods in moderation. Don't drink a whole lot. Make sure your BMI is normal. Exercise. And all this, in general helps your liver. Anything that keeps you healthy, your body healthy, will keep your liver healthy as well. So basically, make sure you don't have anything treatable that can cause liver disease, and do everything else to kind of live a healthy lifestyle. For example, it's recommended that every adult in the United States be now tested at least once in their lifetime for hepatitis C. So it would be important to have this done. And more importantly, if you fall among high-risk groups, such as living in a nursing home or using intravenous street drugs, you should be tested more often, because detecting hepatitis C and treating hepatitis C will protect your liver.
You know, you mentioned at the very outset about what is commonly referred to as fatty liver disease, and you mentioned cholesterol specifically. You know, Thomas and I have done a lot of interviews, and we've all heard about cholesterol and obviously cardiovascular conditions. We've heard about cholesterol and how it can create or add to problems with gallstones. And now you're telling me also high cholesterol and obesity can contribute to liver disease. Is that correct?
That's correct. A part of the lipid profile called the triglycerides are specifically what settles down in your liver and causes fatty liver. The important thing here is that obesity, excess carbohydrate intake, the lack of exercise can all do this. And so the reverse is to, exercise and make sure you don't take too much carbohydrates and make sure that the levels are normal, all will protect against fatty liver disease. Not everybody will get fatty liver disease, but if you do, then these are important things to take care of. Obesity in general is probably the most important reason, and losing even 10% of your body weight will help fatty liver disease if you do have it.
You know, we've talked a little bit about some of the diseases. Now let's switch a little bit and talk about some of the tools that you have available to treat liver disease.
So it's important to remember that the liver can compensate very well for diseases, and it's a blessing and a curse. For example, you can take half a liver and give it to somebody else, and both people do well. The bad news is that the liver has to be really damaged a lot before it'll show signs or symptoms of liver disease. So unless you really look hard, sometimes it's very difficult to detect liver disease. Some of the common things we do when you go and see a doctor are to check your liver enzyme profiles, which may or may not actually, predict the presence of underlying liver disease. Certainly, if you start having symptoms of liver disease, such as generalized itching, becoming yellow in the eyes, fluid filling in your abdomen, then certainly those are symptoms that you need to watch out for and go and see a doctor immediately. Apart from that, unless you screen yourself or you're having a CT scan or an ultrasound of the abdomen, those are some of the things we can do to see if you have underlying liver disease or not. The gold standard, so to speak, would be to do a liver biopsy, but that's only done if the physician generally feels you have liver disease rather than a shotgun approach.
We're listening to Dr. Narayanan Menon, the medical director of the transplant program at Medical City, Dallas. When we come back, we're going to be talking about the path to determining when someone might need a life-saving liver transplant. Next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're talking with Dr. Narayanan Menon, who is the medical director of the liver transplantation program at Medical City, Dallas. And for someone facing liver disease, there is a path that you follow prior to the possibility of a transplant.
You know, if you do determine a patient has liver disease, are there any kind of medications that you can prescribe to help the patient?
Yes, certainly. A lot of this depends on what kind of liver disease you have and what's the cause of your liver disease. A few examples are, one would be treatment of hepatitis B or hepatitis C with medications. There are other conditions such as autoimmune liver diseases, which can be treated with steroids, and very rare disorders of iron and copper metabolism, where you actually de-iron and de-copper the human body. So there are a few tools we can use to treat liver diseases.
When you determine treatment is really at the point that you really need to seriously consider a transplant, what are some of the things that you look for, criteria to say it's now time to do a liver transplant?
There are two specific types of liver failure for which liver transplant is beneficial, and also the third category would be patients with liver cancer. The first category is when your liver fails acutely and you become very sick, and that's a condition that's very dangerous to life, and people die in a matter of days. So if this happens, then that clearly is an indication for transplant. The second major category of diseases that benefit from a liver transplant are patients with cirrhosis, which is basically end-stage liver disease from scarring in your liver from a variety of reasons. Once you have end-stage cirrhosis manifest, especially by the development of symptoms such as fluid in your belly or jaundice, so then that's another indication for liver transplantation. And the third indication is if you do have cirrhosis, all risk of developing liver cancer. And if you do have liver cancer that's in early stages, you can be cured by liver transplantation. And there are a few other rare conditions which may be helped by liver transplantation, such as cancers of the bile ducts. And very interestingly, rarely the liver functions well but produces abnormal substances such as amyloidosis. And in this situation, you can be cured by liver transplantation.
When you think in terms of a liver transplant, a couple of questions. You could have a transplant, I'm assuming, if there was an individual that was an organ donor. But you mentioned you could do a living transplant. Can you expand on that, please?
Yes, so the liver is a large organ and has a lot of compensatory abilities. So if your loved one or somebody you know has liver failure and is in need of a transplant, you can actually donate half your liver to that person, and both of you will do well. It's kind of similar to kidneys. Only thing is you have two separate kidneys in terms of kidney physiology or anatomy, but here the liver is one big organ. So they can actually take half a liver or whatever part is needed and make sure that both the donor and the recipient do well. Interestingly, living donor transplant started off with mothers donating a small portion of their liver to their children because as a child, you just need a very small portion. And so this is how it all started, and it has become fairly common now to do this in adults.
Is there ever a time where you would say the living transplant wouldn't be as effective as, say, an organ donor transplant, or do both seem to have good outcomes?
Both have good outcomes, as long as the living donor is suitable. So both have similar outcomes. In fact, the living donor transplant may be a little better because with a living donor transplant, you don't have to wait on the waiting list, waiting for an organ till you become quite sick. You can actually get your transplant with a living donor when you're healthier, and that may help you recover faster from a liver transplant.
To help our listeners kind of comprehend this just miracle of life through organ donations, if an individual, unfortunately, let's say, was in a car accident and lost their life, but they were an organ donor, how soon do you have to transplant that liver into a recipient?
So once an organ or the liver comes out of the donor and put on ice, you generally would have to transplant the organ in the next 6 to 8 hours or so. And a lot of it depends on the donor organ as well, the age of the donor, the amount of fat in the donor organ. But this is almost old story now because there's now a pump you can put the liver on and actually pump blood-like substances through the liver and keep it alive, so to speak. And this might increase the number of hours you can keep the liver going before you need to implant the liver or transplant the liver into the recipient.
So is it fair to say that in metropolitan areas like the DFW area, most liver transplants from Medona are probably within a pretty close proximity? Because if you're looking at 6 or 8 hours, I know you could fly them from other parts of the country, but I would say they'd have to be fairly local. Is that correct, or am I wrong?
Not necessarily. It depends on, these livers are all transported by air. So if you have a sick patient, you can actually get offers from a fairly long way away. And that allocation system has changed recently in order to help patients who are very sick. As you know, they don't have a liver dialysis system. So if you don't transplant a sick patient, the patient dies. And in order to prevent this from happening, there are allocation systems in place that allow for organs to be brought in from farther areas, as long as you're still within the 6-8 hour time limit.
Are there any restrictions as to people who would not be eligible for a liver transplant other than medical conditions? For example, is there an age restriction on an individual might be older than you would prefer to do a transplant?
Not necessarily, but this is a very tricky question to answer. Most programs have an age limit of between 70 to 75, and it's not really the actual age. It's more of a physiological age, because the older you are, the more heart disease you will get. There's more risk of cancers. And the important thing to remember is that when you have liver disease, you also lose muscle mass. And it's being increasingly recognized that frailty is a measure of success after a liver transplant. And if you're very frail, for example, with your liver disease and old age, you probably will not make it through a transplant. You have to remember, though, that a liver transplant is probably one of the biggest operations a person can undergo. And so they really have to be strong to recover well after a liver transplant.
We read a lot about any transplant, heart transplant, liver transplant, kidney transplant, rejection rates. How are we today in dealing with rejection by the recipient of the liver?
So that's a very interesting question. The liver is part of the immunological system in the body. And although I mentioned that the liver transplant operation is technically very challenging, it's actually one of the easiest organs to immunosuppress. And we have very powerful immunosuppressant agents these days. So there really is not a specific number in terms of rejection, but rejection is very easily controlled in liver transplant patients and is generally not a problem at all. And surprisingly, especially among children, if you're transplanted as a baby, you have the ability to come off all immunosuppression in about 30 to 40% of patients even. Whereas it's a little different in adults. They have to stay on immunosuppression the rest of their lives, most of the time. But even in adults, there are now studies underway to see if you become immunologically tolerant. That's the medical terminology. To become immunologically tolerant, that you can actually wean yourself off immunosuppression.
How often do you see liver disease as being hereditary?
Not very common. The most common hereditary liver disease is one where you get iron overload, and even that is considered rare. The important thing to remember is that if you or your relative is diagnosed with one of these diseases, it's important to follow up on it and make sure that family members are all tested for this.
We've been listening to Dr. Narayanan Menon from Medical City, Dallas, about our livers. When we come back, we're going to talk about a new technology that is the ultimate life-saving machine. Find out what it is and how it works next on the Human Side of Healthcare.
Welcome back to the Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. And we want to talk a little about some new protocols that can be used to help cardiac patients. And we're delighted to have with us Dr. Ramesh Subedi, a pulmonologist at Texas Health Harris Methodist Hospital in Fort Worth. Dr. Subedi, welcome to the show.
Well, thank you. Thanks for having me.
You know, before we really get a deep dive into this new program and some of the new protocols, let's first explain some terminology and how it's used. Can you explain first extracorporeal cardiopulmonary resuscitation and also how we use a machine we refer to as a ECMO machine, which is extracorporeal cardiopulmonary membrane oxygenation?
So this ECMO, actually, as you rightly pointed out, it's extracorporeal. That basically means it is outside the body. So what we really do is divert the blood from a patient, and that flows through a membrane in this machine where we oxygenate and take out some carbon dioxide. So in this way, it's replacing the function of the lungs. And then the machine will pump back the oxygenated blood to the patient's circulation. So thereby, it can also bypass the function of the heart. So in a way, it is a heart-lung bypass machine which can provide this, work when the heart and lung is not functional. So that is how it is used in patients' survival by an extracorporeal means.
You know, when you think in terms of the ECMO machine, to kind of give an example to our listeners, was it used in very extreme cases of COVID-19?
Yes, it is a very sophisticated way and higher level of care in which patients who are very, very sick to the point that their heart and lung are not enough to sustain, the basic function of life, that is to supply enough oxygen. And that is the time, those are the circumstances in which this machine is, used to provide that basic function. Again, this is a highly complicated, way of supporting life.
Thank you for that explanation and also that example. Now, even before we get into this new program, can you explain to our listeners what is the difference between a heart attack and sudden cardiac arrest?
Steve, so that's a very good question. I think a lot of people don't have a clear understanding of the difference between those two terms. So a sudden cardiac arrest, as the name implies, is an abrupt cessation when the heart stops to pump, it stops to function, so that the people will not have any perfusion in the body, and they might collapse, they might stop to breathe. So that is sudden cardiac arrest. The most common cause of sudden cardiac arrest might be some electrical problems. And when we talk about heart attack basically implies if there is a blockage in the coronary arteries, that is the arteries that supplies the heart, so that the heart muscles itself do not get enough blood and thereby enough oxygen, those heart muscles are at risk of death. So that is your heart attack. And not all heart attack will probably lead to sudden cardiac arrest. The most common symptom of heart attack would be chest pain, and people will feel dizzy, nauseous. But sometimes heart attack can also lead to sudden cardiac arrest.
You know, it's interesting. Thomas and I were talking prior to this interview, so I'm going to ask you a couple of little probing questions. So if an individual has a sudden cardiac arrest, as you defined it, could that occur even if you have no blockage?
Yes. So a lot of times, even without blockage, for example, if a patient has some metabolic abnormality, which leads to electrical abnormalities in the heart. So if you have an abnormal electrical rhythm, whether it is too weak, too fast, too slow, so those kind of rhythms can lead to a sudden cardiac arrest without having any coronary block it as such. So yes, it can definitely happen. And sometimes sudden cardiac arrest can happen without any inherent problem of the heart, something that, can be caused by the problems surrounding the heart, like in the lungs or the membrane of the heart. So there can be other causes of sudden cardiac arrest besides just the coronary arteries problem.
So if an individual, for example, went in, saw a cardiologist, had a full workup, apparently had no blockages, everything seemed fine, is there a way to test to see if you've got problems with the electrical as you described it? Or is that something that just occurs?
Sometimes there can be some warning signs. For example, sometimes people might feel a skipped heartbeat or their heart is beating too fast and too slow. So that is when you investigate the problems of the electrical supply of the heart. So there are ways to investigate that, but sometimes, as we discussed, it can come without any warning whatsoever. So that's why we call it a sudden cardiac arrest, because then it comes without any warning as such.
You just described, I think, and I'll see if you agree, just how important is learning CPR and the use of AEDs when you see someone experience sudden cardiac arrest.
Absolutely, Steve. Absolutely. As we know, sudden cardiac arrest is potentially extremely deadly, situation here. American Heart Association quotes a number which is very disheartening, very, very dismal. Less than 10% of the patients, Steve, probably 8% of the patients who sustain sudden cardiac arrest will survive. So this is a very dismal number. And the only thing that will ensure or increase the chance of survival is somebody witnesses that arrest and is able to help, and by help I mean perform an immediate and very effective CPR, or if it is available and if you have the right kind of rhythm, then do the AEDs to ensure that there is some degree of functionality of the heart. So that is the most important thing that one can do to help these patients.
I think you've done a great job of explaining to the listeners the functionality of an ECMO and an ECMO machine and how it's outside the body and it helps preserve life, and also grasping sudden cardiac arrest. So with those two elements kind of explained, now let's discuss this new protocol to help cardiac patients, and it's referred to as the ECPR program. What is the ECPR program?
So the ECPR program, as we discussed before, when somebody has a cardiac arrest, we perform a CPR, which is a cardiac pulmonary resuscitation. By CPR, we mean mechanically we try to resuscitate the heart by pressing on it. And as you can imagine, it might not always be very efficient. And as you can also imagine, it's very hard to sustain that while trying to work up the patient and do it for a long time. So there is where the extracorporeal CPR comes, in which we perform the functionality of the heart, that is to pump the blood by oxygenating it by the utilization of ECMO machine. So the ECMO machine is being used to resuscitate the heart. So that is the basic concept of this resuscitation.
When you think in terms of ECPR programs, a lot of them seem new. I think over in Tarrant County, there are only 2 of them. How in the world do you determine the patient criteria for being in the program?
So again, it's not a very readily available program for a lot of different or smaller hospitals to implement this. For that reason, a lot of hospitals in our community do not have this program available. But then again, it has been tried nationally and internationally in big centers. They've come up with recommendations to identify the patients who might have the best chance to benefit from this intervention. So, of course, different centers have different criteria, But what we implement is the basic understanding is one of the most basic thing is you have to have a witnessed cardiac arrest, meaning somebody has a cardiac arrest and somebody sees it and immediately performs a high quality CPR. That means the process of CPR has been started right away. And then the next step becomes for the first responders to respond immediately and know that this is available and to communicate right away to the hospital that this is a potential candidate and start that process. Once the patients arrive in the hospital, then we identify the patient. Are they in a certain age range? Usually in our hospital, in our program, we identify the patients who are more than 18 years of age and ideally less than 65, who have the right kind of rhythm, who had witnessed cardiac arrest and CPR has been performed right away. So those are the basic criteria. And then, of course, we will do a quick blood work to identify whether a very severe damage has already been sustained, because in those cases, these patients, although they arrived at the right time, might not really benefit with this intervention. So we have certain criteria, even before the patient arrives and after the patient arrives, that we rigorously follow, because this is a very intense intervention, and we want to make sure once we indulge in this, the patients have a good chance to benefit from this.
We're listening to Dr. Ramesh Subedi from Texas Health Harris Methodist Hospital in Fort Worth. The ECMO machine, what a device. Makes you wonder if these will be in ambulances one day, or maybe they are now. We'll find out when we come back on the human side of healthcare.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. Continuing our interview now with Dr. Ramesh Subedi from Texas Health Harris Methodist Hospital in Fort Worth about this life-saving device called ECMO. Wanted to also mention our podcast and YouTube channel, The Human Side of Healthcare. Steve?
I would assume paramedics have to be very much involved in this program.
Oh, absolutely, Steve. So this is a program that involves different layers. A lot of people, even before coming to the hospital, are involved in this. So paramedics are really deeply involved. They have one of the most important skin in the game. I mean, they got to know they have to arrive there early. They've got to identify the patients and really know that they are providing a high-level CPR, and identify that those patients, of all the patients that attend, which are the patients that are likely to be a candidate, and immediately communicate that with the hospital that can provide that facility. So a lot of communication, flawless communication is very important. So they play a very, very important role, instrumental role in this eCPR program. Absolutely.
You mentioned that statistic, which is very shocking, that less than 10% of people that experience sudden cardiac arrest survive. If you have a sudden cardiac arrest and someone does administer CPR, you are revived, what are the chances that you could experience it again?
Depends on the cause, Steve. So there are certain diseases which can be recurrent, and there are certain diseases that after you correct it, if you're managing it properly, if you're going to doctors properly, taking your medications, follow up the rigorous process of, follow up and doing everything as you're supposed to do, your chances can be decreased. But again, there are certain other causes which are likely to be recurrent. So yes, once you have a cardiac arrest, you already are in that category of patients that are, prone to have this condition. And many of them, unfortunately, these conditions can be recurrent.
You did a great job of explaining kind of the electrical malfunction, but are there any proactive activities that people can do to try to avoid sudden cardiac arrest?
So sudden cardiac arrest, again, Steve, I mean, ECMO is great. This is a great facility that we have here. But again, the most basic thing, the biggest bang for a buck, is as simple as leading a very healthy lifestyle. maintaining a good weight, going and seeing your doctors and trying to control your simple conditions like your high blood pressure, high cholesterol, so those, and diabetes, those, if you do all of those things, I think those are the most important things to reduce your risk of having a cardiac arrest.
Thank you. Appreciate all your excellent advice. Thomas?
Let me see if I have the ECMO concept correct here. It basically, as I understand it, is a machine that takes the blood from a vein, runs it through this machine where it gets oxygenated, and then pushes it back out into the body through an artery. Is that correct?
That is absolutely correct. So that's why we call it extracorporeal, meaning it's outside the body. So what we basically do is we have a cannula that draws the blood from the patient's veins, okay? And that blood, we need to oxygenate. So we're oxygenating that blood. When that blood flows through a membrane in that machine, we oxygenate that blood. And sometimes we can also remove carbon dioxide from that blood. And then that healthy blood, which is oxygenated and removed of the carbon dioxide, it is pumped back from that machine, from that ECMO machine. It is pumped back to the patient. So that in itself is that ECMO. Yes, you're absolutely right.
What's the difference between ECMO and a ventilator then?
So a ventilator, that's a very good question. A lot of people don't have, quite a good grasp of that basic difference. Ventilator is a machine which still utilizes the lungs for gas exchange, meaning with a ventilator, you're pushing in your oxygen and air inside the patient's lungs. So the lung is still the place where the gas exchange takes place. The ventilator does not replace lungs. But in ECMO, instead of utilizing a patient's own lungs, in some people the lungs is in such a bad shape that it is not effective in doing its basic function, that is oxygenating and releasing CO2. So in those patients in which the lung is so bad that it cannot even function, even with the help of a ventilator, then in those specific cases, we utilize a machine which will replace the function of the lungs and the heart.
Let's talk about time frame here. So, as you mentioned before, you're at a basketball game with your kids, you start to feel clammy, all of a sudden they're giving you CPR. How much time do you have between that moment and death in order to get hooked up to one of these?
If you have a witnessed cardiac arrest, the sooner CPR is started, the better. Because once CPR is started, at least theoretically, you are pumping the blood so that there is at least some kind of perfusion. For unwitnessed arrest, because we do not know how long somebody has been down, it is hard to guess. The body doesn't do very well without oxygen. Brain, if it doesn't get oxygen, people will pass out within minutes. And the vital organs like your heart, your lungs, your kidneys will also start to get affected within a few minutes to 20, 15 minutes. I mean, we're talking minutes, and the body, the tissues of the body will start to die very rapidly, very quickly. And some of these organs, if they die because of lack of oxygen, the changes are irreversible. So this is a very serious condition we're talking about, and we're talking about minutes, really minutes.
There are people who have prepared documents that say, I don't want to be kept alive. If I get to that point, I've lived a good life, I'd just rather go on. Is there that ethical component to this, that you have to check the directives and you have to see what somebody's wishes are as far as going on a machine?
That is absolutely true. Not only for ECMO, but for any resuscitation. If somebody has a directive saying that they do not want to be resuscitated, then the first responders, doctors, whoever witnessed them first have obligation to respect that, and we do not start any kind of resuscitation, either a regular, resuscitation or ECMO. Any of those, that is a contraindication. We exclude those patients from resuscitation events.
Will there ever be a portable ECMO that could be out in the ambulances?
That's a very good question, Terms. That's a very good question. Actually, there are already portable ECMO machines that can, and people have done that in very highly specialized places where they have a lot of experience. They have been doing it in communities like this. There are very small places, very limited places, but they actually are already doing that.
Seems like if it were everywhere, prolific could be a real lifesaver.
Yes, if it is available, rightly done, it is a wonderful technology to be utilized. But again, I cannot emphasize more that in order to save lives in community, the best bang for buck is not ECMO. It is still trying to implement a healthy strategy for a community. Making sure they have access to healthcare, making sure they're eating well, exercising well, and they are seeing doctors and doing things that they're supposed to do. If you do that to community, do that to hundreds of patients, thousands of patients, you have opportunity to save a lot more lives than by investing in highly sophisticated technologies like ECMO. Again, it is very important. This kind of a technology is very important for that individual patient in which that might be the only technology standing between death and life.
We've been hearing the same message from so many physicians we talk to. Take good care of your health. Dr. Ramesh Subedi from Texas Health, Harris Methodist Hospital in Fort Worth. Steve?
Thanks, Thomas. May 11th is a date when the public health emergency ends, which means if you're on Medicaid, there has to be a redetermination. Please make sure that you get all your required paperwork in place as soon as possible. Join us next week for the human side of healthcare.